हेलो।
You are audible. Am I audible?
So hello everybody, on today's very interesting infectious disease forum in immunocompromised. We all know Dr. Neha. She is a brilliant infectious disease specialist doing a wonderful job in transplant ID across the country. She gets calls across the country and she gracefully handles them. This is a series hello everybody on to intellectually discussions taking place on the virtual platform for solving the common problems. And if there is a problem which don't have an answer, we can always forge a tie-ups across the world to answer those questions, because this is ever-growing field in infectious disease, and the country has at last, I would say, awaken to the need of infectious disease specialists. Dr. Michelle and the rest of the people who are listening today, Dr. Neha has brought down our ICU rates by 60%. People going to ICUs. We now have a better prophylaxis regimes. We have started doing FMTs, and she has got a complete control over all these 15 so-called hematologists like us, where we cannot write the antibiotics without asking us. So we are also afraid of her. And the rest of the if you could have seen me in person, then you could have seen the frown on my head that we are like afraid of Dr. Neha for writing the antibiotics without asking her. So that's what Dr. Neha has done. And Dr. Neha, thank you for bringing Dr. Michelle to the audiences across the country and across the region. Without making much of a time, over to Dr. Neha.
Thank you so much, Rahul sir. And first of all, thank you, sir. Thank you, Emcure, for making this as a part of the routine academic series. When we talk about the oncology, hematology, bone marrow transplant, solid organ transplant, one thing which comes to our mind is the different spectrum of infections, different spectrum of infectious diseases. So, in order to take care of them, in order to have a separate thought process and how to tackle them, and more so how to prevent them from occurring in the first place, it's very important. So one of the most notorious bug, I could say, from age across, which every oncologist, hematologist, and any transplant person would have come across, and nowadays with the changing paradigm in the immunity post COVID, even the otherwise so-called immunocompetent adults, when they landed up into the critical care for some other reasons, they also land up in something called CMV reactivations. So this is one of the first educational forum where to cater specifically to the infectious disease forum in immunocompromised to understand the types of challenges in a specified host population. So the first session is about the CMV infections. It's actually a very, very old foe, but yes, with the different paradigm from not only preventing, picking up early and picking them out, so we have a new fighter range as well. And we are very, very honored to invite today on this platform Dr. Michelle Young. She is our old colleague, and she is an honorary and senior faculty at Department of Infectious Diseases at Peter MacCallum Cancer Centre, Melbourne, Australia. I know her personally as a CMV woman of the globally, because she has like worked extensively in CMV. You think about the topic and she has a paper on it. So she is a senior infectious disease physician and a postdoctoral researcher. My God, too much crowded in the CV can show that how big you are, Dr. Michelle. So she is a part of the University of Melbourne and also the National Cancer for Infections in Cancer at University of Melbourne, Australia. Definitely an experienced clinician with so much of research interest in CMV, close to, I guess, 60 plus publications in CMV on every aspect of this virus. More than the CMV itself, she has read that virus more and published widely in the understanding of its related transplant outcomes, specific immunity, and the different guidelines in the management of resistant and refractory CMV. She was a member of organizing committee of the 2021 International Immunocompromised Host Society Symposium in Melbourne. And she sits currently on the so much of guidelines writing panels in the management of CMV and fungal infections in immunocompromised. So without a further ado, looking really forward to learn from you, Dr. Michelle, in the next 30 to 45 minutes. And we have so much to ask for you. So here to go, Dr. Michelle.
Thank you so much. Very, very kind introduction, Dr. Neha. And it's a pleasure to be here and to speak to you. So I will again try and share my screen. Wonderful. Hope you can all see that. Thank you. I love the title of this, the old foe, new fighters. And I love talking about CMV. And as Dr. Neha said, it's sort of a unifying viral infection that we see across the whole spectrum of transplant to critically ill to even neonates and maternal health. But I must admit, I'm an adult trained physician, and I predominantly work in the stem cell bone marrow transplant group, and with some solid organ transplant as well. So what I thought I'd do today is look at, go through a bit of the background of which you would mainly know most about, looking at prophylaxis and preemptive. Some updates, newly published updates on refractory and resistant CMV, which was published 2 days ago. Talk a bit more extensively about some of these new fighters and prophylaxis with letermovir, touch upon immune monitoring, and I think Dr. Now really wanted me to sort of speak about this new frontier of CMV cytotoxic T lymphocytes and our local experience, as well as if we have time to briefly touch on 3 difficult cases. And then I think we're just going to open it up for discussion. So CMV, I don't have to tell this audience, is really the troll of transplantation. And despite all our medical advances, it remains the most frequent and challenging, I think, opportunistic infection in the post-transplant setting. So here we have a figure that I've sort of drawn to look at the whole spectrum of CMV, and it is very common. So it's important because it's common. So roughly around 75 to 100% of our recipients will have been previously exposed and therefore deemed CMV recipient positive. And then post-transplant, we're looking at around sort of 66 to 70% having CMV infection. And by that, I mean PCR detection, so a level of DNA. Doesn't always need to be treated, but certainly it's still a large population. Further than that, as I said, not everyone needs treatment, so we're roughly looking about another 50% who need treatment, and this is now sort of deemed in the literature as clinical infection. And at the pointy end of the spectrum, we have end organ disease. Unfortunately, this has really reduced over the years from around 20 to 30% when CMV disease was quite scary and really contributed to mortality, to now looking really only under 10%. And at the very, very pointy end, we have CMV known antiviral drug resistance, which fortunately makes up a very small percentage. So as I said, a lot of people have had prior exposure, and it makes them both a donor and recipient positive, putting them at risk. And just to point out that with CMV disease, if you're a solid organ transplant recipient, we know that really the lung transplants, and if you're CMV naive recipient, this is your highest risk group. So what's the impact of CMV infection in the current era? So it used to be, well, what's asymptomatic CMV infection if it wasn't causing disease or wasn't causing any symptoms? Well, we now clearly know that even CMV detection at low levels, deemed to be at around 250 international units per mil, still leads to ongoing contributes to overall mortality and non-relapse mortality. And this was nicely demonstrated in a big study by Margaret Green a number of years ago that really showed this stepwise level between any positive viremia in the early days post-transplant, post-stem cell transplant, to even up to day 365. And you can see here on this forest plot that all these plots and confidence intervals are to the right of 1, so increased mortality. Anywhere between the rate of 2 times to up to 20 times the risk of not having CMV infection. And this is also borne out by really large European studies where CMV recipient positive patients do a lot worse with overall survival and increased non-relapse mortality. And the whole aim of trying to prevent or tackle asymptomatic or CMV infection is really to reduce the risk of it progressing to more severe end of the spectrum, which is CMV resistant refractory disease. And I kind of tend to group these up as a bit more complicated CMV disease. So the aim is to prevent this, but it still does occur in this current era, despite our improved diagnostics and improved antivirals. And with resistant and refractory infections, they require a lot of prolonged toxic antivirals. They're often poorly tolerated and we have absorption problems. And as you know, a lot of these we have a limited choice of antivirals. Often they require intravenous support. Not only do we treat the current infection, but the risk of recurrence occurs and there's concurrent immunosuppression that we have to deal with as well. The morbidity and mortality from these resistant refractory disease is quite high, and there are some very well-known sanctuary sites such as the eye and the CNS, which are really difficult to get. And on the figure here is a nice pictorial, which I like to show my registrars and trainees, that when you get called about CMV resistant refractory disease or any questions about CMV, just to let you know that the solid organ transplant donor positive recipient negative and your recipient positive stem cell transplant patients really for the most of the CMV end organ disease burden. So you can see here as highlighted in this sort of yellow bar here. So I alluded to before, the consensus definitions of CMV infection and disease in transplant patients have just been updated and published a couple of days ago. So I was fortunate to contribute to this working group on transplant-associated viral infections. And although it's really important that these definitions get used in clinical trials so that we all know what we're talking about, sometimes they don't translate as well into clinical practice, but just some of the updates which we really debated about quite a lot pertain to the definition of refractory CMV. I think it wasn't really clear in our first edition of these consensus definitions. So we've removed the definition of probable refractory CMV. So it's now defined as any patient who's had at least 2 weeks of appropriately dosed antivirals, and you see either an increase by 1 log or a persistent CMV viral increase or decrease in DNA, which is less than 1 log. And that's now considered or thought to be refractory CMV. And I encourage you to go to these definitions, as there's also some pertinent updates with regards to CMV disease, GI disease, particularly in the solid organ transplant group. So this is just a brief figure, just so that we're all on the same page of what we're talking about when we're talking about CMV prevention strategies. So at the top, we have prophylaxis. And by that, that's like you give antivirals before the onset of DNA anemia. And currently we have some options of valganciclovir, ganciclovir, or letermovir. And the aim is to bridge the patient during their most high-risk period to often day 100, and then come off it. But we do have this problem of late CMV infection. And so what we've done is kick the can down the road, and perhaps at a later time, and we've seen this often when the patients are well, they're out back in the community, they get late CMV infection and disease when they're not as closely monitored. Compared to the preemptive way of monitoring, and this is much more common in the stem cell transplant group just because the antivirals are poorly tolerated. And this is whereby we measure at my centre, we do this twice a week, look at the viral loads, and then if they meet a certain threshold, then we target that and start treating with valganciclovir or ganciclovir. And by doing this, we are using less sort of antivirals overall. We're targeting it towards patients who need it, although we do still need to do lots of monitoring, and there's issues with monitoring. You have to have all the right resources, And again, with prophylaxis at the moment, we still recommend some monitoring, even whilst you're on antiviral treatments. And there's also the issue of resistance. So this paper by Marty et al. In the New England really changed practice and was a paradigm shift in the management of how we treat CMV in the stem cell transplant group. So 24 weeks was our endpoint, where latimovir was started for the first 14 weeks and clearly showed met primary endpoint that latimovir, compared to investigator-initiated treatment, drastically and significantly reduced clinically significant CMV infection. But this was also the first pivotal study to really show that prevention of CMV could also be associated with prevention of mortality. And it wasn't a primary endpoint, but I think this was really, really important to show that, in fact, preventing CMV had more was more significant than just preventing use of treatment. And then earlier this year, we extended, this big study looked at extending. So whilst we had good data up to day 100, in some patients we know that if you're at high risk of clinically significant CMV, whether you've got an unrelated donor, haploidentical transplant, or a cord transplant receiving ATG or T-cell depleted graft, that perhaps going out to day 200 in these high-risk patients would be of benefit. So this was a phase 3 randomized 2-to-1 study of extended latimovir up to day 200. And these were the results of the study. With so you can see here in the x-axis from week 14 through to week 28, there was a significant reduction in the incidence of clinically significant infection at this time point. And a 3% versus 19% in the standard of care. And this was highly significant. And this has led to this registration study to be extended out to day 200. But if you look past week 28, you can see this rapid, if you follow the bottom line, this rapid uptake and upswing of reactivation once you stop prophylaxis. So this is just to demonstrate that, sure, CMV is very well controlled whilst you're on prophylaxis, but there's a really significant rebound or delayed onset once you stop prophylaxis. And I'll go into that a bit more detail later of ways we can potentially tackle this. So now we have great data on latimovir. So real world data, 48 studies, over 7,000 patients who are using primary prophylaxis since latimovir was registered. And without a doubt, it clearly shows that there is lower risk of CMV reactivation, lower clinically significant CMV infection. We now see lower CMV disease, all-cause mortality, and non-relapse mortality. So it's very good at reducing CMV morbidity and mortality. And it's now been assessed in a randomized controlled trial, a non-inferior trial to valganciclovir prophylaxis for those at high-risk adult CMV seronegative transplant recipients having an organ from a seropositive donor. And this was a large, again, randomized controlled study of 601 patients who 1-to-1 were to receive latimovir versus valganciclovir, with the primary outcome being CMV disease at week 52. And the findings were that in the latimovir group, 10.4% had CMV disease and valganciclovir 11.8%. And so it did reach this non-inferior to valganciclovir. But the most sort of clinically significant finding was that really it was much better tolerated, and we had much reduced incidence of neutropenia at 2.7% versus 16.5%, and therefore less use of GCSF, and then less cessation due to an AE in the latimovir group. But the elephant in the room is that not everyone has access to latimovir. and that there's not equity across the board. And I'll state right now that in Australia, all our patients, we don't have national access to Letermovir. So my centre as well, we don't offer this to our patients because it's not reimbursable, although different hospitals also have different regimens where they can access it to particularly high risk patients. Letermovir is expensive. We're now prophylaxing up to day 200, so without a doubt this is expensive, and we know that not all patients will be at the same risk. So an interesting study by the European BMT working group of 180 centres found that prophylaxis, for all the talk of Letermovir, prophylactic strategy was only used in 56% of their centres. And of the prophylaxis that was used, Letermovir only made up 61% and valacyclovir was 19%. Some centres use Valgan as prophylaxis, not recommended, and also Foscarnet. But this is a real world setting. And then we were involved in another study of 15 countries outside Europe and North America, which showed that preemptive therapy was the preferred approach. And in this study, no one had used prophylaxis Letermovir, and CMV related mortality remained high. What's also really interesting is that some of these countries also had reduced access to Foscarnet and Cidofovir, much less access to Letermovir. So what do we do at our centre as an alternative to Letermovir? Well, we actually use high-dose valacyclovir. And by high dose, I mean sort of 6 to 8 grams daily versus what we use is for prophylaxis of HSV is 500 milligrams BD. And we found in a study that there was some moderate and real effectiveness when given at this much higher dose as CMV prophylaxis. And we chose to use this in our CMV R positive, undergoing haplo or T cell depleted, or of being high risk. And we compared to this a previous cohort of historical control, and we found that there was significantly reduced incidence of CMV reactivation. So here on the figure here on the right here, in the red line, we have the patients with standard dose valacyclovir, and you can see here nearly over 80% reactivated overall. And when using a high dose valacyclovir prophylaxis, we see in the blue line and shaded area here a much reduced CMV reactivation. And also, it also delayed the onset of clinically significant CMV infection. So this was quite significant, and this is what we mainly use in the absence of widespread Letermovir. Not everyone does this though. And we took this data from the umbilical cord transplant pre-Letermovir days, which also showed marked reduction in poor outcomes from CMV. So for all that talk of prophylaxis, I do want to point out there is still some good data for the use of a preemptive strategy. And this is a really great study looking at the capsule study, which was in liver transplant patients and RCT, comparing 3 months of preemptive therapy versus 3 months of universal prophylaxis. And in fact, they found that preemptive therapy was superior to using universal prophylaxis. So CMV disease in that group was only 9% versus 19%, which was significant. And more recently, it was published on the late sort of 5-year survival of these patients on this RCT, and showed that the patients who were randomized to preemptive treatment did much better in 5-year survival, with 92% versus universal prophylaxis at 79%. So I thought this is a really interesting high-level RCT data to show that preemptive therapy was superior. So in speak to my colleagues, we really look at this data, but unfortunately, some people haven't taken it up so much. So it's much easier to put people on universal prophylaxis, you need to have a really good system and follow-up for monitoring throughout. And so I think we're going to sway back to trying to use preemptive therapy, particularly in this group. And I've already heard also the renal transplant groups are looking at going back to preemptive therapy. So I talked before about this delayed CMV immunity. So colleagues at the Fred Hutch, Daniels and Moran had looked at what this meant on patients who were on latimovir prophylaxis compared to a control. And it was a really neat study, which kind of went to show from a lymphocyte perspective and a CMV-specific immunity perspective that reducing CMV antigen exposure whilst you're on latimovir does result in a delay in immunity. And at 3 months, it really showed that polyfunctional CMV CD4 positive response was significantly lower than in the controls. And that even if there was a little bit of shedding, or what sometimes we might refer to as more blips or low level of CMV DNA anemia, patients who had that whilst on latimovir actually had increased CMV T cell responses observed. So how can we potentially harness monitoring the immune system, and is there a role for this in our prophylactic strategy? So just a little bit about immune monitoring. It's a method of perhaps maybe having a personalized approach to how we approach CMV prophylaxis. Potentially it can improve our risk stratification. So this diagram shows that whilst everyone has a very similar immune suppressive period, predominantly in the first 100 days, after that the risk really diverges from low risk to high risk. And how can we better identify these patients? Immune monitoring really should help us to potentially guide primary prophylaxis, hopefully to predict bad outcomes and also predict spontaneous clearance. And I've been working in this area for some time. It's a bit more advanced in the solid organ transplant group, but it's currently probably not in regular routine use, despite some data to really support that. And why is that? Well, at the moment, there is some diversity around the CMV immune testing, and it's not standardized, and you can use anything from quantiferon to ELISpot to flow. But just some brief data to show that CMV immunity can sort of identify those who might have CMV disease. So we can see here on the left, if you're familiar with the quantiferon, the patients who had an indeterminate result, all of them were associated with CMV disease. Versus if you had reactive, like none of these patients went on to have associations with CMV disease. And we know that immune risk can also predict your CMV peak viral loads, with obviously increasing or improving immunity, having better control and lower CMV peak viral loads as seen here. I better move on. Just a couple of the recent studies about maribavir for resistant refractory treatment. This is now a great option that we have for resistant refractory bad CMV. This was shown in a phase 3 RCT of both solid and stem cell transplant, showing that it met the primary endpoint for clearing of CMV virus within the first 8 weeks, compared to investigator-assigned treatment. And I'd be interested to see how widespread you're using maribavir in your centres. It's been a great option for us. But somewhat disappointing was the Aurora study, which was looking at maribavir for first episode CMV viremia, or as part of the preemptive strategy. And this was published just several months ago. Phase 3 randomized double-blind 1-to-1 maribavir versus valganciclovir, looking at the asymptomatic first episode CMV viremia. So this figure here shows assigned to maribavir versus a standard of care valganciclovir, and the primary endpoint was at 8 weeks CMV clearance. And it was a non-inferior study, which they had pre-specified that 7% was non-inferior. However, at 8 weeks, it was found that maribavir did not achieve non-inferiority. So the numbers were that maribavir at week 8, those that achieved was 69.6% versus Valgan, which was 77.4%. They looked at a number of secondary endpoints, which were also interesting, and did find that even though maribavir didn't reach the primary endpoint, that the viral clearance and probably what's important to us as clinicians, the absence of CMV disease was very similar across week 8. Those that achieved, importantly as well, patients tolerated the maribavir better than valganciclovir, so only 21% treatment associated AEs, and only 4% had to discontinue it due to neutropenia. So my conclusions from maribavir for this setting was, unfortunately, it didn't achieve non-inferiority. So we are left with the absence of potentially maribavir or a new agent compared to valganciclovir in this space. So I'll move on to talk about third-party CMV cytotoxic T cells. And these are a novel way of tackling the virus by restoring immunity versus, in addition to sort of attacking the virus. So this has been around for quite some time now. And just to let you know that we received T cells from either Atara Biotechnology, which is based in the US, and we're fortunate to have a lab in Sydney and one in Queensland, of which we can obtain cells. And it's been used in a variety of scenarios, so either prophylactically or therapeutically in the setting of persistent viremia, resistant CMV virus, and also CMV disease. And the way I like to express this or tell my patients or my registrars is that by restoring the CMV specific T cells, we're sort of hastening or hoping that they would be reconstituted, and over time, usually several weeks, what we do is we see CMV get better. So I just want to share with you some of our experience for using CTLs. We've got a number of patients now, and I presented this at ECMID early this year, 12 patients who we under a sort of multidisciplinary group of our transplantations and ID physicians approved the use of CTLs. And this is really for refractory CMV and also those who just couldn't tolerate the standard antivirals. Most of these patients were transfused at about day 190. And pleasingly, though, the cumulative incidence of virological response we found was great at 78% and taking a median of 20 days. Of course, we found virological response to be 78%, but the sustained virological response dropped off a little bit to 40%, and that's because we did have a number of ongoing graft versus host disease and ongoing CMV viremia. These patients were heavily treated, so we were a little bit desperate. So just to show that patients had up to 8 courses of antivirals before they got their CTL. So this is a really difficult cohort. We found that patients who achieved a virological complete response, that the duration of CMV infection that they had before the CTLs was up to 151 days. So quite a long time dealing with CMV. But then after having CTLs, only 38 days. We also found that the antiviral use before CTLs was up to 52 days. And then after, the median was only 3.5 days. So we found this to be very effective. And you can see here on the right a swimmer plot showing in the middle here, we have in the blue dot and day 0 when all the CTLs were infused. And on the left here was pre-CTLs. And in the red here, you can see all this shaded areas was patients with viremia or DNAemia at the time. And to the right of those blue lines, we have all the duration from the time of the CTLs, and in the blue shaded line is follow-up, but in the absence of CMV DNA. So we found this to be very effective and significantly reduced our CMV complications. So I'll just spend 3 or 4 minutes on a couple of cases. So a 67-year-old haploidentical R-D negative transplant recipient undergoes an early first CMV reactivation day 45, and that's easily treated by standard valganciclovir, and that resolves without a problem. However, then he goes on to develop diarrhea and has subsequent grade 3 acute graft versus host disease. And with that, we saw a rapid rise of CMV up to 25,000, and we start IV ganciclovir. But it fails to reduce by more than a log. And so we left in this scenario of a refractory CMV infection. And in this scenario where we're suspecting resistance, it is recommended that you switch to an alternate agent whilst awaiting the genotype. So we did this to foscarnet, and fortunately no mutations were identified. So then the question became how long should we treat refractory infection for? And we took the option of following the guidelines, which does say about 2 to 4 weeks with an optimally selected dose antiviral, with the aim of achieving 2 consecutive undetectable viral loads. So this was achieved without too much trouble. And then we asked the question of what should we use for secondary prophylaxis? And we went on to give valganciclovir, and I've got this little chart here on the right-hand side, which we're in this section here, valganciclovir prophylaxis. And despite being on this, there were little blips along the way, and viral load doesn't completely achieve undetectable consistently over that time. And so we thought, well, should we switch to latimovir? And the current recommendations are that we shouldn't do this in the context of a viremia due to the low barrier of resistance. It gets trickier because neutropenia, of course, develops as we see this with valganciclovir. So we don't reduce the dose, but we do give GCSF support, and we try and reduce his immunosuppression. Unfortunately, he has ongoing symptoms, and a repeat colonoscopy shows in fact, this time he has CMV colitis confirmed with inclusions, and the viral load jumps up once again to 70,000. And this time we do find UL97 and UL54 mutations. He was part of the maribavir study, and so we had access to maribavir, and then you can see very nicely here the viral load goes down, and I can report that he's done very well at this time when things were really tricky at one stage. The second case is a 21-year-old with ALL who undergoes an umbilical cord transplant and develops proctitis, and he's of course a CMV R-D negative. And we see and confirm CMV inclusion bodies with immune histochemistry. But at the time, his peripheral viral load was very low. It was not detectable, but at 91 international units per mil. We start valganciclovir, and because of this sort of low peripheral, it becomes undetectable quite nicely and very rapidly. However, he continues to at least clinically be unstable, with CT showing extension of the colitis. And so here we have probably clinically refractory CMV colitis without measurable viral load in the blood to tell us or guide us. He goes to ICU, develops renal failure from foscarnet, so we really get stuck of what to give next. So the question of CMV IVIG comes up, and in fact, a randomized controlled trial looking at this, at least in GI disease, shows that this is not recommended. We can't use cidofovir because of renal impairment. We would, at this point in time, use maribavir, but it wasn't available at the time. People still talk about leflunomide or artesunate, but I must say we don't use it, and I can't remember the last time we would use it. The data is really poor in that. So instead this was one of the cases where we used CMV, third-party CMV-specific T cells, and he did well on this. And the last case is a pediatric case, 4-year-old male, R+D+, who undergoes a haploidentical donor transplant and has suspected CMV resistance quite early on with UL97 mutation detected. And unfortunately developed CMV retinitis, and we get ophthalmology and of course ID get consulted. And one of the lessons learned from this is that really we should aim to try and get aqueous fluid as well as peripheral blood to send that off for CMV PCR and also genotyping, because it's well recognized and documented that you can have compartmentalization of your mutations in the eye versus blood. So we attempt to do that, but unfortunately we aren't, as is often the case in real life, we aren't able to get enough fluid to be sent. So we continue on IV foscarnet during that time. However, clinically, again, this patient deteriorates and reports double vision. And so we get stuck with what to do next. One of the lessons here is that we really can't use maribavir in this scenario because it's a CNS infection and it's not recommended. Again, third-party specific T cells have been known to be useful in this scenario, but in the end, actually the clinical symptoms resolve, and he also, this little boy, does well. So to conclude, I really wanted to show you that CMV, although we've made great advances, and like you said, we're not so worried about it anymore because we feel that we do have a lot of good management options, but it does remain really challenging and it is still such an important infection. We've had significant practice changes over the years, really shifting towards prophylaxis in the stem cell transplant field. Is very effective. However, it's not perfect, and there is ongoing delayed CMV immunity and late CMV disease and infection. Perhaps we'll also see a shift in the solid organ transplant back to a preemptive strategy. It's a little bit early, but certainly when talking to colleagues, there is a tendency to perhaps shift in that just because of the really good data on better outcomes. So how do I see the future in CMV? Well, I think identifying this and better characterizing the prolonged risk period and immunosuppression is required. Hopefully we can do this with improvements and advances in our immune assays to personalize the duration of CMV prophylaxis or treatment. And I didn't talk about this so much in this talk, but really some of the new agents or these new fighters, there is some data to show emergence of antiviral mutations are of some concern. So whilst we have them, and what we see with all our antimicrobials is whilst we have them and use them effectively, even in clinical trials, we see mutations are occurring. And so we really do have to be careful. And with that, that's my last slide. Thank you very much.
Great. Thank you so much, Dr. Michelle. That was really very, very enlightening for all of us. I mean, the journey from prophylaxis to preemptive to definitive therapy. And clearly, I've always been thinking, because how CMV is bad as a bug, I think more bad is the drug. So yeah, so there's always a challenge between the infection, the gancyclovies, the cytopenias, and especially with the resource limiting settings, when we have no much equity and equitability, what you showed in one of your slides, to both the letermovir and as well as maribavir, things are a little more challenging this way. Yeah. So thank you so much for your talk. And here comes the next part, which is actually a very interesting part. I would say that we have a lot of queries and we have a lot of more insights to gain from you regarding the CMV. I mean, more towards the practical solutions which we are facing day in and day out. So if I may like to ask, ma'am, that considering letermovir is a very big buzz to talk about these days, right? both in terms of the SCT as well as in SOTs as well. So the question is that specifically, as if I talk about, say, there is a patient who is haplo transplant, day 30, day 40, we started them on the preemptive therapy because we got a viral load. Today's report, we had a today patient as well of 12,000. We started her on the ganciclovir. We have no other options for the primary preemptive therapy. And after 2 loads, say we get the report as negative. And of course, in that 2 weeks' time, because the patient is still just day 34, they have to complete a whole lot of 2 months to reach that 90 days. So the bone marrow is still fragile, getting up. Sometimes the ganciclovir suppresses. So is there any role of secondary letermovir prophylaxis in these kind of population?
Yeah, no, there is a role for secondary. It's not the approved indication, but yet more and more people are using, once you've got good control of your viremia, and like you said, you're still in that high risk period, and we know that valganciclovir will end up causing the patient neutropenia. If you can get the viral load down, I would switch over to letermovir. Much less toxic on your bone marrow, especially for these newly engrafted patients.
Agreed.
Can I ask? You've got access to letermovir?
So fortunately, we got a very, very limited access. So we have used letermovir at our center in 6 patients, those who were being able to procure. Unfortunately, we were not able to give them the entire 90 days or say 100 days, but we targeted to the most specific days, that is till day 45, which is the most dreaded situation. So we were able to not see any kind of breakthrough in all those 6 patients when we used till day 45. But yeah, one of them had a late breakthrough, which comes to my next query as well, ma'am, that the patients you have kept on letermovir, so suppose there is no time range and you have to have a specific population and for a specific time duration, what it could be. So if you have a limited access to letermovir, so yeah.
Great. This is a great question, which we have come across too. Like, if we can't give it to all our R positive, who are we going to pick? And this has caused a lot of contention. Some experts feel that you can never predict really well. But what we have decided is an R positive and use of ATG. Haplo is definitely in there. But really keeping it to the almost R-pos-D negative group as well. So we find that R-pos-D positive, probably if they were to get viremic, they could, a shortened duration of valganciclovir probably a bit more tolerated in that group versus the really high risk group. So they were the things that we identified as a consensus in our institute of who we would give it to.
Right. So something like a targeted approach, that the seropositivity there would matter, because we belong to the area where we have a seropositivity of say more than 95 to 98%. So majority of ours is plus and plus. So I mean, So
So if you're plus and plus, then I would take the T cell depleted ATG or the haplos. There was a study, a French study, which looked at all their letermovir patients, and they tried to risk stratify, and these were some of the risk factors that they came up with.
Understood. So any role like you mentioned about, so I'm very interested in knowing that there was one more paper in the last year, which actually pre-haplo, they just checked about the IgG titers. So we just, because in our country, because everybody's seropositive, we see, okay, CMV IgG positive, fair enough, that is it. But just by looking at that number, 500, 250, 300, can we somehow predict the rate of reactivation, and that becomes a targeted population?
So we're talking about the IgG pre-transplant titers. Yep.
Yes.
So very interesting question. We don't see the titers. What we get is a reactive or non-reactive. So we would have to go back and have a look. They have done things in the past which didn't find ongoing predictive ability. But I do know the Fred Hutch and some colleagues there are going back to look at it. So that's Michael Bock's group. They've got a whole heap of patients. So they're going to look at it, that exact same thing. So watch this space. If that were the case and we could predict, that would be wonderful. Somehow I feel that it might just be too simple a solution, but anything which can help predict that risk would be great.
That's true. That's true. I mean, the targeted, the priority, I would say the lottery system, whichever way it works, yeah, it has to be there.
Yeah, I think it's not going to be the be all and end all though.
Correct. And especially like we have to pick and choose practically to get the procurement and the access and everything. I think that strategy will go a long way. So meanwhile, I would request all our other delegates if they can post their questions in the chat box so that we can discuss on this forum, because I find that ma'am is really helpful to gives us a lot of insights. So yeah. So one more just question, ma'am, that during the peri-engraftment period, this is specifically in terms of the stem cell transplant, because there are a lot of times we have a consensus, I mean, a query that peri-transplant CMV prophylaxis minus the letermovir, as we said, that we don't have an access. So considering the availability of GAN bar valganciclovir, foscarnet limited, and acidofovir, barring that the artesunate or leflunomide. So these are the options if I give that, what would be the best way put forward in that 14 to 21 days of engraftment time to take care of CMV?
So if they reactivate day 14, so do you see that commonly? I must admit, I don't see that very commonly.
No, not much commonly at all. I mean, I would say very, very limited population, but yeah, given a choice that if I have to give it a prophylaxis, say they have a pre-transplant already a reactivation at the time of their chemos, and the very few 1 to 2% population where I have to keep them at a prophylaxis, does that 1 or 2 weeks? Because here there has been some sporadic experiences using the cidofovir once a weekly for say 2 weeks or 3 weeks till your engraftment is happening. So any light on that?
Yeah. Yep. Now, sorry. Yep. No, I see what you're saying. So the very high risk, we have patients who have got peri-transplant already, some CMV detectable. It's often low. We institute high dose oral valganciclovir from about day 7 onwards. And if it's significantly higher or is worse, we can use foscarnet. No one likes to do it. I haven't used cidofovir, I must admit, and we find that the toxicity is too high and not able to be safely monitored. We have now had about 5 years experience using high dose valganciclovir. Patients hate it. It's a lot of pills, and you do have to still watch out for neutropenia and a bit of renal failure. But even if you get a 30 to 40% reduction compared to standard dose, we'll take it.
I agree, because another limiting factor with us in the adult is the concomitant nephrotoxic drugs going on. So yeah, that's a major challenge, because with cyclosporin, of course, they're not gonna bargain on that. Peri-transplant, we need to have some kind of antibiotic support in someone the other way. Again, a nephrotoxicity with the high dose valacyclovir, so the combination looks a little for anticipatory as well. Yeah, and yeah.
Well, so the concern was high dose valganciclovir contributing to renal problems, and when we looked back at all our patients, we didn't find it. So even in our particular cohort, we didn't find a signal that things were worse. So we've just continued on with it. But the concern was there. I hear you.
Understood, right, ma'am. So yeah, one very, very important question. I mean, I would say $1 million question for all our transplanters, be it the solid organ or the SCT, optimal cutoff of treating CMV.
I love it. It varies. I do find that the US groups are very aggressive with their viral load cutoff. So often they won't tolerate anything, really above 90 in their haplos. And so they treat aggressively at the start. We're a bit more with the European side, which is tolerating something up to 1,000 international units per mil. Somewhere between 500 to 1,000, we would start our preemptive therapy. In our solid organ transplant group, sometimes we go up to 1,500 with watch and wait. That's often, they're often down the road, like day, 3-6 months down the road. So we can, if we've got the support, watch and wait. So anywhere between sort of 500 to 1,500 international units per mil. It also really depends on the trajectory. It's scary when it comes back 12,000. But often, sometimes under 500, what we see is it goes to 400, and then it can, sometimes we just see it drop off on its own.
Okay. So the question is that the one question which I have one or two questions in the chat box as well, but just to complete on this part, that suppose we have a patient, because many times it happens that asymptomatic, otherwise the engraftment is going on in a slow and paced way. We found somewhere around, say, 1,050 copies or something, math sibling, nothing to do. Do we still wait? Do we consider this as a blip? And considering an allo, do we need to treat?
About 1,000, you say?
1,050 copies per ml.
We would probably treat that unless there were other reasons that they weren't going to do well and we could observe. I must admit, we would probably start treating at that stage, and we would start with the valganciclovir as an outpatient. Mm-hmm. That's not to say some people would probably wait for a little bit higher, but I would say we would treat.
All right. So there is one question, ma'am, from the chat box. I would like to ask that, is there any role of ethnicity in implicating the CMV reactivations?
What a wonderful question. I haven't seen any data with that, but I welcome, particularly at your centres where you're dealing with a lot of different ethnicities, that would come. Mainly I deal with the Caucasian population, some Southeast Asian, but we just wouldn't have the numbers to look at that ethnic difference. I'd love to see some data on that.
Yeah, so because we have been seeing a lot of patients, ma'am, who are coming from the African continent and like sickle cells and THALs, and we have seen that they reactivate quite early, and that's why the question of asking in the peri-transplant period extrapolates from that population, because we have seen those people tend to reactivate quite early in their transplant period, close to, say, day plus 10, the minute the count start coming up. We are collecting the data for that as compared to any other ethnicity we have come across. So, yeah.
Thank you. I'd love to learn more about that.
Right. I think one more question before we go ahead. If we were to develop a point of care testing for CMV, would you rely on a nanopore-based sequencing, or you should still stick to the oldest gold fact? That is the traditional test which we are talking about. Very interesting question, ma'am. Yeah.
Thank you. I'm probably not the expert in this area, just to say that we would love and welcome a point of care testing, don't you think? Something that could be done by the bedside, CRISPR technology is around as well, and so that would be interesting to see if that could potentially be developed as a point of care bedside test. I'm not familiar so much whether the nanopore would work, and at the moment, just a traditional PCR is still the mainstay of monitoring. I'd love to see this develop. It would really help our patients who live a bit further out, who aren't being monitored, and which it's still quite quite an expensive test, really.
I agree. But I have a curiosity to ask that how bad is a bug versus how bad is a drug, especially in the copy number of say 200 or 300, considering the fact for the next 2 weeks. So suppose we have to have a subsequent two number clearance. Giving ganciclovir for 14 days in a engrafting marrow, I would say, versus a 300 copy number, otherwise not doing, but yeah, we picked up.
Yeah, I think in that scenario, the drug is the worst. You know, coping with the drug is probably worse than the virus if it remains at that sort of limit. And you know, it's really interesting, the Francisco Marti study, which showed decrease in mortality overall in the Latimavir group versus investigator assigned, where you just use GAN, Valgan, Foscarnet, whatever you had. I do wonder how much of the drug component that reduction in mortality contributed to, rather than just the virus. So it's a really interesting question, but no doubt drugs are awful in the stem cell transplant group.
Right. Just one more query about the definitive therapy, or I would say the organ specific. So I always used to wonder, I mean, this is my personal question to you on this platform, that whenever a patient develops, say, a CMV colitis, and we usually tend to give it for, say, 3 to 4 weeks, what should be the end point of it? Because we have seen many a times discordance in the blood PCR numbers versus the organ involvement. So it's not always go agreement and hand in hand. So do we need to do a check colonoscopy or a sigmoid before stopping it, or 3 to 4 weeks with the closure of clinical symptoms is a good enough parameter to carry?
Yeah, good question. I think if in the scenario where they're clinically getting better and everything's going to plan and there's no GVHD, I would be comfortable just go to 3 to 4 weeks and sort of stop. I don't routinely do a follow-up colonoscopy to have verified that the CMV has gone. The reasons I would do it is if you're questioning another opportunistic infection or another issue, so ruling out, you know, it's other infections or GVHD. And in that scenario, the patient's usually still got diarrhea or pain or some sort of issue.
All right. So one more question, that ganciclovir versus valganciclovir, any difference in the efficacy? Is ganciclovir preferred early post-transplant, even if the mucositis has resolved and the patient is able to orally take? I think that's what the person wants to ask.
Yeah, no, that's a good question. We have a preference for valganciclovir, an oral agent, if the patient can take it and there's no issues about mucositis, or we really reserve IV GAN if the viral load is extremely high and you really want to get it down, or they're coming in, or they really can't take an oral drug because of GVHD or something. There's probably no difference in true efficacy, but certainly it's more about the patient and whether they can take it and absorb it.
Yeah, I agree, because we do also have a close to 180 patients data where we have given the upfront valganciclovir because of its ease to use and a very user-friendly, no hospitalization, and we could found a similar success rates, as you said, except the GVHD or a too bad a mucositis for some reasons. Yeah.
Yep.
Moving on, any role of IVIG? You have already shown in one of your slides, but the CMV specific IVIG, any role, how to go about it, specific indications, we would like to know, ma'am.
Yeah, so I really looked into this for the guidelines for the resistant refractory CMV disease, and it's important to remember that the studies looking at IVIG or CMV specific IVIG were really before we had good effective antivirals, ganciclovir, really. So it's traditionally been done, and depending on the setting, we do sometimes give it to throw the kitchen sink at the patient because they're just doing really badly. But the data doesn't actually show that it's of any use, except probably if you've got bona fide CMV pneumonitis. Otherwise, and good antivirals that are tolerated. And I've steered away from using IVIG because the evidence is not there.
And in case if we need to use as a salvage therapy in pneumonitis, any frequency of
Yeah, so if you've got pneumonitis, there is a little bit better data for IVIG, and there's no difference between CMV specific versus IVIG. Yeah, and there's nothing to say that you need repeated doses, but probably just getting one dose in is recommended.
All right. Okay. One more questions. I mean, one or two more. In the terms and the definitions of refractory CMV, when we talk about, suppose if the majority of the patients have concomitant immunosuppression going on, there is 50% of the 50, okay, there is 15 to 20% of the population amongst them, which is going for, say, a GVHD, other kind of immune mediated diseases for which they are on steroids, Jakavi, etc. So how we actually justify this term of refractory CMV in those population, ma'am?
I think it's still like, I think if you've got a viral load, you can just fall back on your hard definitions of viral load and the fact that it didn't drop as expected by 1 log after 2 weeks of therapy. It is probably harder to define it clinically if you've not got a viral load to look at in the setting of immunosuppression. And the reason we sort of harp on about refractory is really so that you can get access to something like maribavir or the next step up, and to make an application, compassionate access use or DTC, so that we're all on the same page.
And then in that regards, we had 1 or 2 pediatric patients who were, kind of struggling. So considering maribavir is not approved, I guess, below 12 years of age because of the safety data. So in that scenario, again, ma'am, the question goes back to the point zero, that what could be the next step? Yeah,
the poor pediatric patients, they're always the last to get any of these drugs approved. Letermovir is coming out, and I think maribavir, they're going to go down to age 12, greater than 12, but it really leaves the really young ones up in arms. CMV CTLs have a lot of good use in pediatrics. So the big group, Lean et al., they're actually pediatric hematologists who use a lot of CTLs. So if you have access to that, and there's CTLs against all the different adenovirus, CMV, EBV, if you could get a program going which allows you to get cells for that, I would use that over an antiviral.
Understood. So we have one patient who has taken for the CTL. Of course, the turnaround time of us to procure and get it on the board is 2 weeks minimum. And then many a times, going back to that situation where the CTL level has been achieved, patient is already on sometimes of the concomitant immunosuppression because of GVHD, landing up to a situation like this, which we know. So how in majority of your experience in CTL, what's the average number of sessions of CTLs being required to get the better clearance of the viremia, ma'am?
Yeah, we sometimes get given, it depends on the lab, we get given sometimes 3 to 4 doses per that request. It depends on how many CTLs that we're able to get. And it is difficult with graft versus host disease. So generally recommend not to give the CTLs if you're greater than 0.5 milligrams per kilo prednisolone, just because you're giving it and then it's just stopping it from working. So I don't think the effect I don't think the effect is related to the number of cells, but just how well those particular cells get uptake and reconstitution in the host, the quality of it.
Quality of it, yeah. Okay, so one very interesting question again, that till what time in the allogenic transplant specifically, if one had a prior reactivation early in the course, till what time we need to keep monitoring the CMV viral load?
Yeah, if you've got resources, as we know, CMV can happen at any time within the first year. Minimum the first 100 days. We monitor a bit further if they've got GVHD or they've got ATG or there's other complications. I'd say minimum the first 3 months. Even then, we really, in reality, probably go out to 4 or 5 months.
So, ma'am, any role of monitoring the host-specific, say, B and T cell subset or the NK cell subset to guide that decision?
Yeah, that's a really good question. We don't do it. I don't think it's been correlated. I've asked at different centres, like whether a simple, like with the HIV T cell subsets, how can that correlate? I know some paediatric people do it, but they don't use it to guide and make decisions. So I haven't seen any specific data about it, but just people tend not to recommend or use it to guide decisions.
And the same way, I guess, the CMV quantiferon, which you mentioned in one of your slides beautifully, that if we get the same question, just to extrapolate, even if we get the CMV specific immunity on board, so can we stop monitoring? But I think we need to get more and more data about it. I guess how it works.
Yeah. So at least that's looking at your CMV specific responses versus just a generic CD4 and NK. So if we can develop those assays to be a bit more accurate, and then if it's reactive and it shows that there won't have any complications, that would be really helpful.
Right. I think we have 1 or 2 questions more because this is getting really excited time by time. Okay, so moving, I would say from C to A and B. So suppose we have a patient who has A, the adeno, B, the BK, and C, the CMV.
ABC, now I get it, yeah.
So ABC of transplant, suppose you get the concomitant one or the other. And suppose many a times we also see the concomitant EBV alongside the CMV taking a toll on marrow. So how to go ahead in that area? Can Cidofovir be some ray of hope or something?
Oh, this is I'm very interested in this topic. I didn't show the slide, but what we found is that patients can have up to 5 different viruses at the one time, or subsequently within the first sort of 100 days. And you're absolutely right. Once you see CMV, you're at risk of EBV, adeno, even if not at that time, subsequently. I think you just have to tackle one thing at a time. And what's the most predominant virus? We didn't even, actually B is BK, right? BK virus. We see a lot of BK and hemorrhagic cystitis as well. I don't have any tips. Tackle your most troublesome virus, and then it's like that hammer, you just knock one down, the other one comes up, you just got to knock that down and cross your fingers.
Right. I think any role of the IVIG or something just to keep them at the bay, or
Yeah. No. So IVIG, if the immunoglobulins are low, give it. Yep.
Right. I think no more questions. One more question in my mind, that considering we are now moving into the direction from transplants into a lot of CAR-T. So CAR-T is a new flavor of the season. So of course, it's no less than any kind of BMT, the way it moves further. So the same way, ma'am, the question extends to that. How is your experience in terms of the incidence of CMV reactivation in the post-CAR-T patients? I'm talking right now of the CD19, the most prevalent one.
Yeah. So when CAR T started, it was a big concern. And of course, if you get your cytokine release syndromes and you're needing a lot of steroids and that all contributes to the overall net immunosuppression and risk of CMV. So I think Josh Hill and his colleagues out at Fresh Hill have about to publish a big sort of cohort on that. They do find viruses to be a problem, but not, I would say probably not as big a problem as undergoing an allo transplant. So less frequently it's noted. I'd say in the order, I'm looking at the data, I think so under 15% of the cohort.
Okay.
So yeah, but I think when we first started doing CAR T, we're using a lot of steroids, so it was a lot more frightening. But now we've learned more about how to manage that. We're not seeing as much as high incidence.
Well, I don't think any further more questions. People have got more sanity and more insight today about the CMV. So yeah, if there are no more questions from my side as well. Okay, yeah. So thank you so much, Dr. Michelle. It was indeed a great talk, and nothing more better to inaugurate this IDF5 forum with your session. We became more and more sane, and as we say, we practice and we preach more, and we preempt and we prevent more as far as the CMV is considered. So thank you so much for being a part of it, to give us a great insight about the CMV, right from its journey till the end. Endpoint is still to meet. Yeah, thank you so much from my side. And I hand over to the Emcure people to give a word of thanks to Madam.
Thank you very much, Dr. Michelle. And thank you very much, Dr. Neha Rastogi Panda. And I thank the whole team of FMRI. And we could, this is our greatest pleasure to host Dr. Michelle Young as well as Dr. Neha. And I would request Dr. Rahul for closing remarks if he is there.
I think Dr. Rahul is not here. Dr. Michelle, any final closing comments if you want?
Oh, no, just to thank you. That was so enjoyable. I love talking about CMV, and well done on starting this initiative, Dr. Neha.
Thank you so much. Thank you. I think Dr. Bhargava is not able to join right now. So on the behalf of my team, everyone, thank you, Dr. Michelle, once again for being a part of it. And thank you, Emcure team, to make it as a very smooth and enlightening event for all of us. Thank you all the delegates who have joined and given us more questions to talk about and ponder about. And we will be back next month with another session on the IDF5 forum. Thank you. Thank you so much.
Bye. Thank you.
Bye-bye.